Good morning, everyone. We are seeing the interesting case for the discussion. A 48-year-old male with two prior surgery, 6 months, having persistent perianal discharge. The key question is it recurrence or is it mixed complex anatomy? Because the every time we call recurrence cannot be recurrence. It might be something surgeon might have missed to deal before taking the incision. On examination, we see induration at 6 o'clock, external opening at 6 o'clock, contralateral 7 o'clock. There is induration, adequate squeeze and resting pressure, but there is something high tone in the intersphincteric area. We did the MRI for this patient. The MRI, one is axial T2 fat suppress, another one is axial T2. We can see coronal, how the green bar is going. Yellow bar has been fixed at anal verge, anorectal junction. Green bar is going above. Green bar is going above from anal verge to the anorectal junction. How the green bar on the right side move up, the left side axial will show different area, might be at the low, mid and high area. Once we have seen that, then we are trying to track the disease. This disease we can see here, which is ascending above, and we can appreciate that this bilateral ischioanal outside the external sphincter coming and inserting at a 6 o'clock, and that sees the internal opening. The internal opening here and internal opening is joining here. This is the internal sphincter, this is the external sphincter, and if we see the internal opening green at the mid, means it is more than 30%. Obviously this is a high transsphincteric tract, so we need to think that the crossing is there at the high transsphincteric, means it needs a sphincter preserving procedure. Now the distal tract we need to assess. The distally we can appreciate that when we go little bit up, then when we go little bit up, we can appreciate this is going on this side, this is going, the hyperintensity is going on this side is clear, this side is hyperintensity is going. So this means there is left infralevator or refill, infralevator or refill. If suppose this area is very clear, we call this as an refill collection. If this area only hugging to the levator, then we have to tell refill. If it is hyperintensity seen in this area also, this is an infralevator we can call. So below the levator there is a collection. We ask radiologist to mark red for the red for the external sphincter, means surgeon the outside the red, inside the red. That's what the disease. Yellow is dirty fellow, the fistula. So it will become very easy if you and your radiologist sync together, think about what disease is. So then we can deal completely. So once it is done, we see this report. This is not needed. What we need is, we need images. We ask radiologist to draw a red, means outside the red it is extra sphincter, infralevator and having high transsphincteric tract. Posterior sagittal, we can see that high trans going to deep postanal space, and the axial T2 going into the deep postanal, bilateral horseshoe and 6 o'clock internal opening. We can see and coronal, this is left side completely reaching up to the skin, right side it is blind ending. So this all information, if we code the color for the radiologist, they can give. More than this, what actually, this is a summary form. Actually this has been published and proposed by Dr. Rajna. What we need map is, first is ask internal opening, means we need to take a call what need to be done, pattern, what type of surgery need to be done, perianal space, what are need to be dealt, and distance approximately, so where can be external opening. So summarize, fistula map is internal opening at 6 o'clock, means I need to do the central disease excision at a 6 o'clock. Intersphincteric space tract, it's mentioned only a tract, it is horizontal tract, clear the tract. If it is high tract, having a high intersphincteric disease, deroot the disease. High tract, that is a high transsphincteric tract, we need sphincter preserving procedure. And distally, it is going to deep postanal space, we need clearance of deep postanal space. Right ischioanal, it is a blind ending. Left infralevator, we need to curate. Ischioanal perianal, we need to core out. And external opening at a 5 o'clock. So this kind of information we can get from MRI if we align with it. And The identification of patient in prone position, we identify internal opening at first, and we go intersphincteric space as good as we do in the lift. Then we isolate the tract both the side by using the instrument. Once we isolate, rather than ligating in intersphincteric space, we excise the central disease, that is a proximal disease excision, P of the PILTEC procedure. And then once we excise the proximal disease, that is central disease excision, we go for intersphincteric clearance. I is intersphincteric clearance. Intersphincteric clearance is something, is very important component. Almost 1/3 of the patient will have intersphincteric component, either cavity. We cauterize the intersphincteric space, we excise the complete horizontal tract, and we see almost 8 to 9% as a high intersphincteric component which need to be dealt. Once we cauterize the intersphincteric space, we go for the distal. We are very much clear knowing that 5 o'clock external opening which is going, we just map out on the patient table what is seen on MRI, map on the patient, so that very less likely we miss something. We take a track as it has been shown on MRI, reaching to the external sphincter, and then we are digging out the infralevator component which is going along the external sphincter on the left side and till the levator lower margin. It might be a refill which has become an infralevator or infralevator. From the right, we are reaching into left, we are reaching deep posterior space outside the external sphincter, decompress the deep posterior space, reach to the right side, which is the component which has been not drained. And whatever induration, we had almost 8 days difference between the surgery and MRI. Induration has extended, that also we have taken care. We probe the tract which has been passed, and we are just curating all distal disease. Just drain, debride and allow for dependent drainage. Drain, debride, allow for dependent drainage. And we are placing infant feeding tube. We have seen that one limb is going below the levator, and we are just taking care of internal opening, and we are taking the mucosa, closing the mucosa completely. We have ligated the internal opening, and followed by we are approximating the mucosa to reduce the wound size. And then medially, if it is done, then we have to think about what can be done for the distal disease. Skin bridging, a rubber band we can place. The intent is dependent drainage. The skin incision doesn't matter, any incision we take, it will heal by 3rd to 4th week. It won't be a matter. The pain component is the anal pain. It's not the skin pain most of the time. Just put the tube and patient will go for wash, and we just flush. He can wash at home. Now this is the post-op 1 week having big wound. At the 1 month, almost all seton and tubes we remove by the end of 2nd week. At the 2nd month, we see complete perineum healed. And we do all the complex recurrent cases. Pre-operative MRI is no question, but post-operative MRI also do. The intent of post-operative MRI is the only mirror for the surgeon to clarify that his technique is working. And believe me, if you start doing post-operative MRI and learning and comparing with pre-operative MRI, you will make sure that your technical skill, your thought process, your understanding of fistula improves a lot. So post-operative MRI, patient coming at a 3.5 month, we just done post-operative MRI. Comparatively, you see there is complete hypointensity, and there is as good as no fistula has been seen, which has been confirmed by clinical scar. So friends, this is the MR-guided 4-component strategy for treating the fistula. The first component is internal opening. We do proximal disease excision, part of the PILTEC. Second component is intersphincteric area. We do intersphincteric disease clearance, intersphincteric space clearance, where if horizontal component we excise, if the cavity we curate, and if there is a high extension, we lay open inside. And invariably 27% of our cases have seen intersphincteric component, which is one of the most important component for another one recurrence. Transsphincteric part, there is very simple. Just if down, do the lay opening. If it is crossing above, do the ligation. We call as a PILTEC strategy. L is for LT is on the track over the external sphincter. L is for ligate if it is a sphincter preserving surgery you want to do, and L is for lay open if it is a low track. High track, low track, hope concept you can take call. And if suppose if it is a recurrent, you want sphincter preserving surgery, what we call is layered repair. Lay open and do the layered repair. So L is the PILTEC, LT component is for the external sphincter. C is curate or core out. If the tract can be cored out, if it is under the beneath the skin, just core out. If it is going across the sphincter, just curate. So C is for curate or core out. So simple way, if you understand the MRI, to imply your MRI thought process on the patient, and you will see the magic that your results are enhanced. And I invite all of you for dedicated MR Fistulogram workshop at Crisicon Vizag for learning this kind of skill, and it is easily learned by any surgeon who wish to learn it. Thank you, and subscribe our channel, Dr. Samrat.